Good morning, everybody. At the onset, I would like to thank Dr. Sandeep Jasuja sir for giving me this opportunity and all the organizers organizing such a beautiful conference. For health reasons, I am very sorry I could not be there, so I will be doing this online. So my first talk is on optimizing treatment for first-line non-small cell lung cancer. The stent is in functions, and this has been provided to me by Roche. So in this particular session, these are the things that I will be covering. One is the disease background, evolving landscape of lung cancer treatment, the IMpower 110 study, the 150 and the 130 study, and I'll summarize everything at the end. So is it visible now?
Yes.
Yeah, okay. Okay, so 15% of patients with non-small cell lung cancer are never smokers. The median age of 70 years and typically present with cough, chest pain, and dyspnea. Metastasis occurs late in the disease process, and 55% of the patients have distant disease at diagnosis. And that is why knowing the up-to-date management of advanced lung cancers becomes more important. Targeted agents have improved survival rates, non-small cell lung cancers with ever patients. So initially we had chemotherapy, then came anti-angiogenic therapies, then came targeted therapies, and then probably the game changer was cancer therapy in lung cancer at a very poor process. There is an unmet need in the treatment of patients with non-small cell lung cancer with no actionable biomarkers, because patients who have actionable biomarkers tend to do very well with targeted therapy. So there are significant percentage of patients, what is seen in this slide, about 5% of patients don't currently have any targetable mutations. Obviously, this for 2-3 years would definitely become different as they are discovering new markers in lung cancer every day. But patients with non-targetable mutations tend to do much more poorly as compared with patients with targetable mutations. So can you share the slides from there? I think that will be better. Can you share the slides from your side? I've emailed it this morning. Next. 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 Okay, so this is what we will be discussing. So the IMpower 110 was basically, it compared atezolizumab to chemotherapy to find if atezolizumab monotherapy was better agent than chemotherapy in PD-L1 selected chemotherapy naive patients. And in the IM30 130, they wanted to figure out if steroid sparing chemotherapy is a better partner combination for atezolizumab, because as we know, steroids tend to decrease the efficacy of immunotherapy. The next thing that IMpower 150 said was, does the addition of atezolizumab with the standard of care, that is bevacizumab plus chemotherapy, have any additional clinical benefit? And is there improved clinical benefit if bevacizumab is replaced by atezolizumab? Next. So this is the first study that we will be discussing, where atezolizumab monotherapy was compared with a platinum agent, that is cisplatin or carboplatin, plus pemetrexed or gemcitabine in first-line non-small cell lung cancer. Next. So this is the, it's a randomized phase 3 multi-center study where they took stage 4 non-squamous or squamous non-small cell lung cancers, where there were chemotherapy naive, PD-L1 selected, EGFR ALK negative, which is basically what most immunotherapy studies have taken. And they gave atezolizumab and followed by atezolizumab maintenance. And in the non-squamous, in the chemotherapy arm, basically either it was PEM carbo for adeno, and squamous they used gem carbo or gemcis. And after which maintenance pemetrexed was allowed. So here they have used SP142 as the companion diagnostic. Since they had TC3 or with more than 50% of the tumor or more than 10% of the immune cells having positivity for PD-L1. So this was the Ventana SSP 142. Next. So one can see that the patient characteristics are well matched in both the groups. So there is no difference in the patient characteristics in both the groups. So it was a well matched study. And next. Yeah, now we see the primary endpoint, which was basically overall survival in these TC3 or IC3 expression subgroup. And if you look at the 6-month and 12-month overall survival, there is a significant difference. And this difference actually starts increasing beyond after the 4th month it starts, where the curve starts separating, and they keep increasing after that. So if you look at the median overall survival, it is it improved by 7.1 months with atezolizumab over chemotherapy. Next. So what one learns from this particular slide, that definitely in these patients who have very good expression of PD-L1, there is a significant benefit in overall survival, which actually is a very good primary endpoint. And this next slide shows us that the overall survival benefit was seen by and large in most subgroups, but definitely in these patients who had TC3 or IC, that is, they had the highest amount of PD-L1 expression, they tended to do better, as most other clinical studies in immunotherapy have told us. So it showed a continuous OS improvement, and the hazard ratio was 0.76 as seen in this particular study when atezolizumab was compared to chemotherapy. So one must note in this that 35% of the patients in the control are also receiving chemotherapy. So most of these patients were actually finally in the end exposed to immunotherapy. And that is, but even then, by and large, if you look at it, giving first-line atezolizumab, especially in these patients who have very good PD-L1 expression, definitely improves the overall survival. So that's why the hazard ratio favored atezolizumab versus chemotherapy after adjusting for subsequent immunotherapy use. So definitely immunotherapy has a very good role in this particular subset of patients. Next. So they did a pre-specified analysis to see. This has always been a confusion for us, right? Because when you send a lung panel, every company now generally does the 263, Ventana 263, but are all comparable. Now the blueprint study has said that the least comparative one is the SP142, but then they found that in patients who had TC more than 50%, even in SP263, they also did have a significant benefit in overall survival. But definitely, I would suggest you do the companion diagnostics, because it is much safer, especially when government approval comes in. If the companion diagnostic was not used, we might get into trouble later. Next. So the updated analysis also showed that there continued to be a clinically meaningful improvement in the progression-free survival when a patient was put on immunotherapy first. And as you can see, there's a good separation of the curves, and that is almost parallel to each other. So in these overall response rates also improved with atezolizumab at 40% versus 28% when compared to chemotherapy, and duration of response also was significantly higher in the immunotherapy arm as compared to chemotherapy. So the atezolizumab arm and the pool monotherapy population demonstrated a favorable safety profile. You see these, whatever you see with immunotherapy, no new, safety, this thing was found in this particular study. So as you see, chemotherapy has its typical adverse effects like nausea, vomiting, neutropenia, which we're seeing more. And the immunotherapy has its own set of adverse effects, which was not something drastically different from most of the other clinical studies. So it represents a promising first-line treatment in patients with high PD-L1 patients. And I have used this in patients with PD-L1 high, and they do tolerate it quite well. The 110 study is a positive study that demonstrates statistically significant and clinical meaningful improvement in OS. The safety profile was consistent with prior observation with no unexpected signals identified. And it has a favorable safety profile compared to chemotherapy, and safety data were consistent from those from pooled atezolizumab monotherapy population. So the next study that we will look at is the IMpower 150. Which basically is a phase 3 study of atezolizumab plus chemotherapy and bevacizumab in first-line non-squamous non-small cell lung cancer. So it's a 3-arm study. It's a phase 3 study. The key clinical questions that we wanted to answer with this study was, does the addition addition of immunotherapy to standard of care, which is basically an anti-VEGF agent with chemotherapy, add any clinical benefit? And is there any additional benefit that is got when bevacizumab is replaced by atezolizumab? Is there any loss of benefit? Can that become the standard of care? So this is the 3-arm study. And the reason why they have tried to combine both of it is bevacizumab inhibits VEGF-mediated suppression of the dendritic cell maturation, enabling efficient priming and activation of responses, normalizes tumor vasculation. Atezolizumab has anti-cancer immunity to T-cell mediated cancer cell killing, is further enhanced by bevacizumab VEGF-mediated immunomodulatory effects. So atezolizumab's anti-cancer immunity was supposed to be enhanced. So these are the baseline characteristics of the patient. 14% of the patients had liver metastasis at baseline, which was which were a stratification factor in this particular study. 10% of the patients had EGFR mutations, which actually are important because, post EGFR mutations on targeted therapy, if patients progress, what do we do next? So this is one of the protocols that is commonly used nowadays. If no new mutations do develop, which are targetable. So one can see there's a significant OS benefit in the wild type arm. The improvement in median OS of 4.5 months is clinically meaningful, and it is sustained over a long period of time. So one can see the overall response rates also were significantly higher when both drugs were combined with chemotherapy. And this was seen especially, but in the patients who had the high PD-L1 expression, actually, atezolizumab was better than bevacizumab. And in PD-L1 low, there was no much difference between bevacizumab and atezolizumab, like if you do not want to combine the two. So, but obviously the combination has shown better responses. Duration of response also was significantly better, 11.5 versus 6 months when compared to the standard of care. And the AT arm, 11.5 versus 8.3. Next. So in the PD-L1 high population, one can see the hazard ratio of 0.70. The median survival was 15 versus 30 months when compared with the chemotherapy arm. The OS benefits was observed across all PD-L1 groups, as can be seen in the present figure. After targeted therapy to EGFR, there are not too many options. So in these particular patients, next, this particular combination that took 10% of the patients with EGFR who had progressed is something that has shown some benefit. Next. Next. So one can see that there's a PFS benefit. The Kaplan-Meier curves tend to separate it around 6 months. And if you look at it in EGFR mutated patients, the hazard ratio is 0.60. When you compare arm B versus arm 3, that is the standard of care versus giving 4 drugs. In these EGFR positive patients, I think giving all 4 drugs is something that must be done rather than just bevacizumab or atezolizumab alone with chemotherapy. Next. So there were continued clear separation of curves with OS benefit when all the drugs were given, as can be seen with the hazard ratio of 0.74. Next. Overall response rates also improved from 42% to 71% with the addition of all 4 drugs. Duration of response improved from 4.7 to 11.1 months. So definitely in these particular difficult to treat patients, there is definite benefit. In the liver metastasis subgroup, next. So clinically, a meaningful PFS benefit was observed from arm B versus arm C in patients with liver metastasis at baseline. The median PFS was 8.2 versus 5.4 months. Next. So the Kaplan-Meier curves separate early, and they tended to separate for a period of time, at least up to 27 to 30, after which there is a little bit of overlapping of the curves. But that obviously means that further, crossover was present and further new therapies were given. So addition of bevacizumab, it improved the duration of response definitely, and in patients with bulky disease. Next. Next. My slides are changing a little slow, I'm sorry. So when you look at high and low metastatic burden disease also, right? So in these patients who had clinical benefit was seen in patients with kidney disease, they have defined kidney disease or equal to and defined as metastatic. So patients with disease also tended to actually benefit more in this combination, as the quantum benefit was there not only as well as bulky disease, but quantum was more with bulky disease. Next. There were higher proportion of treatment-related adverse effects of special interest. Arm B, this was expected due to the additive effect. Okay. Am I audible now?
Yes.
Okay. So IMpower 130 is the next study we'll be going through. This is a phase 3 study of carboplatin and nab-paclitaxel without atezolizumab. So basically, the goal of KIT is to create a more favorable environment, maximize the potential of the immune system to eliminate cancer. So that is why immunotherapy was tried in this particular study. Next slide. So this basically they're trying non-steroid dependent, basically in nab-paclitaxel we can avoid steroids. Steroids have a negative effect on immunotherapy, and that is why non-steroid dependent chemotherapy was in combination with 2-1 randomization. Crossover from arms were not permitted, but as you can see, 41% of the patients in the control arm crossed over to atezolizumab arm, and switch maintenance to pemetrexed was permitted in the control arm. As I said before, there is not.
Dr. Robilo, you're muted. If you can hear me, you're muted, sir,
Yeah,
and your
sorry,
time is
sorry.
up.
Okay, I'll just finish
Yeah,
it quickly.
you just have a minute to conclude, please.
Okay, so let's go to the conclusion slide. Yeah, so the previous slide. Yeah, so this was a positive phase 3 study for atezolizumab in first-line non-small cell lung cancer, which is an alternative chemoimmunotherapy combination. It demonstrated statistically significant and clinically relevant OS benefits with atezolizumab. It demonstrated a PFS benefits with a higher overall response rates when atezolizumab was added to carbon pacli. OS and PFS benefit was seen observed across key clinical groups, except in patients with EGFR ALK positive or patients with liver metastatic, supporting the use of IMpower 150 in these patients. Atezo plus chemo had safety profiles with consistent adverse effects associated with single agent therapy with no new safety signals identified. I'm very sorry about the internet, and I thank the organizers again for this wonderful opportunity.
Thank you, Rohit. Thank you, Rohit, for your nice presentation. Now our second